Так, вправо-влево листать. Спасибо большое. Good morning. Let's wait 2 minutes for wake up other students, and we'll start our lecture number 2, inflammatory diseases in maxillofacial area. Okay, thank you for aiding us. Please put plus in our chat if you hear me well and see presentation. Okay. Okay, let's start. Inflammatory diseases in maxillofacial area. The signs and symptoms of inflammation can be uncomfortable, but others show that the body is trying to heal itself. I think it's understandable for you. In clinic of maxillofacial area, maxillofacial surgery, the odontogenic inflammatory diseases are one of the most widespread kinds of pathology. They differ by the large diversification of clinical course that give a causing for their various classification. In absolute majority of cases, etiology of inflammatory diseases of maxillofacial region is contamination of odontogenic infection. Only part of cases, from 2 to 4% nearly, the microorganisms can be brought from separated focuses of other organs. Agents of purulent diseases of maxillofacial region are the Staphylococcus, Streptococcus, Escherichia coli, and others. And here on this slide you can see classification of inflammatory diseases in maxillofacial area. And as you can see, we can divide it into two big groups, odontogenic and stomatogenic infections and non-odontogenic. Of course, we are interested in odontogenic infection because we are trying to learn or to understand stomatology or maxillofacial area diseases. What does it mean, odontogenic and stomatogenic? That means that it's an infection that originates within a tooth or in the closely surrounding tissues. For example, gingiva, oral mucus, salivary glands, and others. And if we are talking about particularly odontogenic infection, that infection which originates within a tooth. And non-odontogenic, it's a big group for us. It's infection that doesn't originate within a tooth. For example, it can be dermatogenic, otogenic, tonsillogenic, rhinogenic, and others. And the traumas, of course, we can delay here. Spread of orofacial infections, routes of spread by direct continuity through the tissues, by lymphatic to the regional lymph nodes and eventually to the bloodstream, and by the bloodstream. Of course, it's rare, but for example, it can be thrombophlebitis, and they may propagate along the veins, entering the cranial cavity via emissary veins to produce cavernosus sinus thrombophlebitis. And it's very dangerous, as we understand, and because of it, because of these complications, we have to take patients in hospital. And on this slide, you can see causes why we can find inflammatory diseases in maxillofacial area, and it can be bacteria, viruses, fungus, and physical factors, for example, traumas, overheatings, foreign bodies, immunodeficiency states, and chemical factors. And we are starting, or we begin to talk about periodontal diseases, or as you can understand, it's periodontitis. Periodontal infection is initiated by specific invasive oral pathogens that colonize dental plaque biofilms onto surface and host immune response to inflammation, plays a central role in the disease pathogenesis and modified by other local, environmental, and genetic factors. Periodontitis is defined as an inflammatory disease of supporting tissues of the teeth caused by microorganisms, resulting in progressive destruction of periodontal ligament and alveolar bone with periodontal pocket formation, gingival recession, or both. Periodontitis usually develops within abundant plaque and calculus or tartar beneath the gingival margin, which hasn't been adequately treated. Tartar is a hardened plaque, a concretion of bacteria, food residue, saliva, and mucus with calcium and phosphate salts. In periodontitis, deep pockets form in the periodontal tissues and can harbor anaerobic organisms that do more damage than those usually present in a simple gingivitis. The organisms trigger chronic release on inflammatory mediators, including cytokines, prostaglandins, and enzymes from neutrophils and monocytes. The resulting inflammation affects the periodontal ligament. What does it mean, periodontal ligament? It's ligament, circle ligament around the surface of the tooth, of each tooth. Gingiva, cementum, and alveolar bone. The gingiva progressively loses its attachment to the teeth, bone loss begins, and periodontal pockets deepen and gingiva recedes. Tooth migration is common in later stages, and tooth loss can occur. Risk factors which can cause periodontitis, of course, they are modifiable, and we can say about plaque, smoking, obesity, diabetes, especially type 1, emotional stress, and vitamin C deficiency. for example, scurvy. Addressing these conditions can improve the treatment outcomes of periodontitis. And here on the slide you can see tartar and plaque. You can see differences between them. The tartar, it's a hardened plaque, and plaque, it's a soft biofilm on tooth with food residues, saliva, bacteria, and other components. And here you can see reduced bone level, and it's a typical for periodontitis. Classification. American Academy of Periodontology now distinguishes three forms of periodontitis. First, it's a necrotizing periodontitis. Then, periodontitis is a direct manifestation of systemic disease, and strictly periodontitis. And let's talk about them. Necrotizing periodontitis is a particularly virulent, rapidly progressive disease characterized in beginning by necrosis or ulceration of the intradental papillae, bleeding gingiva, and acute pain. Patient can't eat, can't drink, can't sleep because it's a pain during day and per night. In some patients, inflammation also involves the oral cavity, and in this case, we can name it as a necrotizing stomatitis. This disease is caused by axial infiltration of the gum into the gingival tissues. The first areas affected are actually the interdental papillae, as I said, and the interesting thing about this condition is that they have been strongly correlated with the stress and poor oral hygiene. In fact, the earlier term for this condition was trench disease or trench mouse because it was associated with soldiers in First World War. And on this slide you can see swollen gingiva and oral mucous ulcers. And swelling of intradental papillae. Aggressive periodontitis severity is now classified as stage 1 through 4 and rate of progression as a grade 1 through C. Periodontitis can begin anywhere between early childhood and older adulthood. Important severity factors include amount of loss of attachment of soft tissue to teeth, depth of pockets, and amount of bone loss, which we can see on X-ray or CT. Periodontitis as a direct manifestation of systemic disease is considered in patients who have inflammation disproportionate to plaque or other local factors and who also have a systemic disease. And such diseases we can name a lot of. And of course, first of all, it's a diabetes, scurvy, in immunodeficiency states. And if we are talking about hematologic diseases, it can be acquired neutropenia, granulocytosis, leukemias, and a lot of others. And as you can see on this slide, it's a measurement of the depth of gingival pockets. And the first picture shows us healthy gums. From 1 millimeter to 3 millimeter, it's a normal, it's anatomical normal. And second picture, it's a beginning of gingivitis, and we can see plaque under the gum, and reddened gums, papillae, and severity of the process you can see on these slides. Symptoms and signs we can see on these photos. And what we can name as symptoms and signs. As mentioned before, there's a bleeding, swelling, and reddened gums due to the vasodilatation. There is formation of spaces between the gum and tooth, referred to as a pocket. Bad taste, of course. Halitosis, yes. Losing and drifting of the teeth in later stages. Yes, it's usual for periodontitis. Changes in bite and formation of abscess. The fact is that the tissue in periodontal disease can vary from one individual to another. Some gums are very reddened due to the vasodilatation and bleeding easily on probing, while other gums look darker in color and have bluish appearance. It's important to realize that in classic periodontitis there is no linear progression, but rather a series of remission and exacerbation similar to many other chronic diseases. And here you can see a lot of plaque above and under the gum. We can see it, receipts of the gums, reddened, bleeding, of course, during brushing or maybe during eating hard food. Drifting of the teeth, changes in bite, and as a result, we can see losing the teeth. How can we diagnose periodontitis? Of course, first of all, it's a clinical evaluation. And the next, for understanding what stage is it, we have to do measurement of the depth of the pockets between tooth and gingiva and X-ray. On X-ray, we can see losing the bone or reducing of alveolar. And on this photo, on this X-ray, you can see normal position of on X-ray signed as A, and reducing of bone or alveolar walls B, C, D, and photo D shows you measurement of depth of the pockets. And clinical photo, you can see periodontal abscess, and we'll talk about it later. How to treat periodontitis? Of course, first, it's a treatment of modifiable risk factors such as a poor oral hygiene, diabetes, and smoking and this can improve outcomes. For all forms of periodontitis, the first phase of treatment consists of thorough scaling. It's a professional cleaning with hand and ultrasonic instruments, and root planing. What does it mean? It's a removal of disease or toxin-affected cementum and dentin, followed by smoothing of the root to remove plaque and calculus deposits. Thorough home oral hygiene is necessary and includes careful brushing and flossing to help clean not only teeth but the area between the teeth. It may include chlorhexidine swabs or rinses. Another approach is to surgically eliminate the pockets and recontour the bone. Pocket reduction, or we can name as elimination surgery, so that the patient can clean the depths of the normal sulcus between the tooth and gingiva. In certain patients, regenerative surgery and bone grafting are done to encourage alveolar bone growth. And here, let's stop, and you have to understand that we can make conservative treatment and surgical treatment. And surgical, it's an elimination of the pocket by surgery. It's a pocket reduction or elimination surgery. And on this slide, you can see bone grafts. Key points, you can read it by yourself. And the next type of periodontitis, it's strictly periodontitis. Bacterial infection of the tooth and surrounding tissues progress rather slowly, but every step is so much more severe than the previous one. Cardiogenic bacteria will first tear enamel down. Then they will bore through dentin. When they or their toxin waste get into the pulp, pulpitis occur. Without immediate treatment, pulpitis can cause irreversible damage and require root canal treatment. If no treatment is performed, the pulp will eventually die off through necrosis. At that point, the tooth is considered dead, and in essence, it becomes a staging area for bacteria to spread further. And our immune system will at point try to stage a defense around the apices, root apices of the dental root. Microscopically, the battlefield containing neutrophils remains, released enzymes, nets, and dead bacteria make up pus, and a lot of it can accumulate given the severity of infection. Enzymes from the pus will irritate the surrounding tissues, creating an acute phase of apical periodontitis. And on this slide, you can see severity or infection which goes from outside to inside. First of all, it was intact tooth. Then caries due to bacteria, phosphates, acids, and other factors, genetics, pulpitis, when these bacteria goes down or deeper into the center of the tooth, and it can be irreversible pulpitis, then necrosis of pulp, and if pulp is dead, or if pulp dead, we can say that it's a dead tooth. Then bacteria and can goes down to the root apices and go through it to the periodontium, and we can say about periodontitis, and we can see it on X-ray. If periodontitis isn't treated, and we'll talk about it, that even years it can be silenced and patient doesn't know about it, that on his roots he has inflammation or inflammatory process. Then in sometimes we can see our patient can claim on severe pain and other symptoms. We'll talk about it. It will be periostitis or abscess. And then necrosis of the bone part of the jaw, and this is osteomyelitis or inflammation of the bone marrow, and then cellulitis. As we can see on the English literature, it's a purulent cellulitis, and in Russian literature we name it as a phlegmon. And as I said, pus can we can see pus formation. The accumulation of pus is called the periapical abscess, as it surrounds the root. This abscess can eventually form a sinus tract, which is narrow passageway that extends from the abscess of the mouth, through which the pus can drain out. The periapical abscess can also progress into periapical cyst, which is fibrous tissue, and immune cells around the area of chronic infection contain the pus. In less fortunate cases, periapical lesions on maxillary teeth, cyst can form a fistula to the maxillary sinus, causing a severe case of sinusitis. If the external drainage fails to happen and cyst or abscess continues to grow, the lesion might progress to osteomyelitis, which is the inflammation of the underlying bone, or purulent cellulitis. Treatment of periapical lesions usually involves antibiotics to curb the infection. Then the endodontic therapy is performed, where the decay pulp is removed and abscess is drained. The pulp space gets thoroughly cleaned and disinfected, while the tooth crown is repaired, allowing the dead tooth to continue doing its mechanical function of chewing. Endodontic therapy has a high success rate. However, the treated tooth can sometimes get reinfected, and an extraction may be required. During periodontal inflammation, there is increased secretion of gingival fluid, which becomes very similar to pus and is sometimes referred to as a purulent exudate. Because this purulent exudate can be secreted freely from the gingival pockets, the patient usually doesn't feel any pain and therefore doesn't take any treatment for periodontitis in timely manner. Once a while, due to the misplaced calculus, for example, of food, the orifice of the pockets become clogged, and the purulent exudate has no place to escape. When this happens, the abscess may form. Abscess, therefore, is a localized area of intense inflammation which results in swelling and possible fever and intense pain. Those abscesses can be confined to the gingiva only, or they can spread to deeper structures and are then known as a periodontal abscess. Abscess, which is non-treated, can destroy the entire bony support within a very short time, resulting in loss of the tooth. It can also lead to potentially dangerous and fatal conditions such as cellulitis. The first way to treat this abscess is, of course, to establish a drainage and then perhaps use antibiotic treatment. And once the acute phase subsides, then a treatment to eliminate the causes needs to be taken, for example, tooth treatment or tooth extraction. And on this slide, you can see photos of different types of abscesses. Periapical, gingival, periodontal, and pericoronal. And of course, it looks like they're similar. And if you are not stomatologist, you cannot understand what are the differences between these types of abscess. On first photo, it's a periapical abscess. And for example, we'll compare this with periodontal abscess. A tooth with periapical lesion is not necessarily periodontally involved. Probing may reveal no pocket depth of node, and no bone loss may be apparent on X-ray. And if we are talking about periapical abscess, only the area is involved, it's periapical area, and other stages or other spaces between root periodontal ligaments and the bone is not involved in this inflammatory process. But if we are talking about periodontal abscess, it's necessary of involving all spaces from the tooth surface and to the root epic or apices of the roots. What does it mean, gingival abscess? It forms in the space between the gum and tooth inside the gingival pockets. I said about it that liquid which forms between but inside the gums can easily drain out due to these pockets. But if sometimes it blocked or clogged by foods, for example, residue, It can lead to the gingival abscess, and pericoronal abscess forms around impacted tooth in stage which when the tooth try to erupt. And outside gingiva, which covers erupted tooth, may be as a cause of inflammation. And on these X-rays, you can see on upper films, you can see periodontal X-rays, periodontal abscesses, and on lower part, you can see periapical. And here, if you try to understand the difference, you can see differences very well. Let's talk about upper X-ray. You can see root, and around root you can see a thin space of shadow. It understandable that in this part we can see bone loss or reduce the level of the bone, alveolar part. And this picture shows us periodontal abscess, because all of periodontium, all ligaments is damaged. And on lower sides, on lower part of the X-rays, you can see periapical. By arrows, you can see this lesion of bone. It's a round-shaped shadow, which shows us damage only that part near apic or apices of the root. It's a periapical abscess. And of course, treatment is quite different. And in most cases, if it's a periodontal abscess and we can see such X-ray, it's indication for tooth extraction. And if it's a periapical abscess, we can try to treat this abscess and to save the tooth. And then we are going to talk about odontogenic periostitis. Periostitis is the next stage, if I can say such, it's the next stage of periodontitis. If periodontitis isn't treated, we can see periostitis of the jaw. Periostitis, or simply flux, is inflammation of periosteum. It occurs as a complication of disease of periodontal tissues if treatment is not available or conducted in a bad phase. Then inflammatory process of periodontal slit penetrates the periosteum. Periostitis, depending on the nature of the inflammatory process, can be divided into acute and chronic, as other inflammatory process in all organisms. Acute periostitis, in turn, is also subdivided into several forms. Let's talk about acute forms of periostitis. They develop within 1 to 3 days. It manifests itself in the form of swelling of soft tissues of the face and fluxes near the sick tooth. Most often, this periostitis is the result of the fracture or injury, because of what it is called traumatic periostitis. The inflammatory process in acute serous periostitis subsides quickly, often without outside interference. Acute purulent cellulitis or acute purulent odontogenic periostitis we can name as acute dental-alveolar abscess. And this periostitis is characterized by distribution of inflammatory process on periosteum of alveolar sprout and body of the jaw. And we can divide it into 2 stages. Early stage and late stage. Early stage characterized by inflammation without soft tissue involvement. And late stage, it's inflammation or abscess with soft tissue involvement. Pathogenic microorganisms gain access into periapical tissue through any of following routes. Infection of periapical tissues through an infected or necrosed pulp of a carious tooth, or for example after traumatic explosion and contamination of the pulp of tooth during, for example, cavity preparation or drilling, through the gingival series from a deeply infected periodontal pockets in case of periodontitis. Extension of infection from adjacent infected tooth, and hematogenous through the bloodstream. Of course, it's very rare, but in classification we can say about it. Deciduous molars of upper and lower jaw, permanent molars of lower jaw are casualties of origin of this disease usual. Clinical findings, it depends from age, the resistant of organism, the type of inflammation reaction, the virulence of infection agent, and the location of inflammation focus. And what we can say about signs and symptoms. Of course, first of all, it's first sign is usually feeling of elongation of the tooth. As the pus accumulates more in the periapical tissues, the patient feels that this tooth is gross, and it's only feeling of the patient. Severe tenderness of the percussion and mastication is manifested. Severe throbbing pain is common in early stage due to the pressure on the nerve endings by effect of the pus accumulation and edema. Constitutional symptoms as fever, malaise, loss of appetite, dizziness, headache, and others. Draining lymph nodes are enlarged, soft, and tender. Lymphadenitis is often involved, is usual symptoms of the acute purulent inflammation. And late stage, symptoms of late stage is immediate relief of the severe throbbing pain. Yes, in late stage, the severity of pain can relieve. Why? Because pus breaks through the cortical plates and escapes into the soft tissues, and usual can even do such sinuses between area of pus formation inside the periosteum and oral cavity. This is accompanied by the indurated, tender, painful swelling, which is brawny, hard and first, and as more pus is formed, fluctuation can be recognized. Inability to open the mouth normally, trismus and dysphagia are not uncommon when the pus is formed. The skin over the entire region of infection is tender to palpation, tense, hard, red, and hot as the localization of the infections occur. A confined, fluctuant mass of pus is seen. The regional lymph nodes are enlarged, soft and tender. It's a lymphadenitis, and of course general symptoms and signs. And on these photos you can see classic manifestation, clinical manifestations of periostitis of the lower jaw. And a few words about chronic periostitis. It's more rare than acute periostitis, and most often it develops on lower jaw. And chronic periostitis is easy to learn for dense edema, which doesn't change facial features. In the field of the flux of slightly thickened bone, next increased lymph nodes. Chronic periosteitis occurs in hidden for several months or years, even years, sometimes sharpening and taking symptoms of acute form, exacerbation of chronic periosteitis. And usual etiology of chronic periosteitis is trauma, when hematoma is formed in the lower jaw, and due to this hematoma, then we can see different forms of chronic periosteitis. And on this X-ray, on the slide, you can see proliferative form of the periosteitis. And here you can see proliferation of periosteum on X-ray. And even if you see, if you take your attention on this X-ray, you'll see periodontitis, periapical periodontitis on this X-ray. And what we can see else, impacted tooth, or wisdom tooth, yes, impacted wisdom tooth. Forms of chronic periosteitis, it's a simple ossification and it can be usual reversible. Ossifying periosteitis, as you can see, the next name is a proliferative periosteitis, and rarefying periosteitis. It's a resorption with following replacement osseous tissues on fibrous. Treatment. As you can see on this slide, it's a physiotherapy in some cases. Of course, tooth extraction if it's odontogenic form, and if it's the cause or etiology of this periosteitis is a trauma, we have to drainage this hematoma under local anesthesia, of course. And if it's acute stage, odontogenic periosteitis, we have to extract the tooth, put the drainage, of course incision, then drainage, and appointments for definitive treatment. Okay, and let's do a break for 5 minutes and then continue inflammatory diseases. Mm-hmm. Mm-hmm. Ну, правильно, только ты же ему скажи, что мы готовы. Деньги у нас есть, соседи все готовы. Только надо договориться с ними. And let's continue our lecture. Uh, please put plus if you hear me because I saw that the sound is switched off and I can't understand. Do you hear me or not? Can you put plus in chat? Вот это не оно? Вот это вот тут вот выключенное?
Нет.
Нет, да? То есть они слышат. Это презентация звук.
Вот звук.
Все, отлично, все хорошо. Все, спасибо, а то я стала переживать.
Нет, я бы проверил.
Все, спасибо. Ага, thank you. I saw your plus. Okay, let's talk about more severe inflammatory process. And this process can be not only in the maxillofacial area, bones, yes, of the face, but on the bones of the body. Osteomyelitis. What is it, osteomyelitis? Osteomyelitis literally means inflammation of the bone marrow. Typically, the process begins as inflammation in the medullary bone, which then spreads into the cortical and periosteal bone. Accumulation of pus and edema within the medullary cavity and beneath the periosteum compromises the blood supply, resulting in ischemia, necrosis, and bone sequestration. Theory classification of osteomyelitis of the jaw consists of acute form. For example, it can be trauma or fracture, odontogenic infection, foreign body, transplantant or implantant. Subacute form, secondary chronic osteomyelitis, like the next stage of acute form, and primary chronic osteomyelitis. Here you can see another classification based on mechanism of infection, hematogenous and exogenous, open fracture, surgery, and contiguous spread from the infected local tissues. Acute osteomyelitis, next classification. There are a lot of classifications and we'll stay on several of it. We can divide into another three groups, suppurative, non-suppurative, and osteoradionecrosis or radioosteomyelitis. Of course, suppurated can be acute and chronic. Non-suppurative can be chronic focal, chronic diffuse, and Gary's chronic sclerosing osteomyelitis. It's a very rare form of osteomyelitis. Predisposing factors of osteomyelitis are sources from which bacteria can spread on bone, from local odontogenic infection, other adjacent structures, for example, otitis media, tonsillitis, suppurative cell adenitis, and others, hematogenous spread of organisms, rare. And on this slide you can see etiology I have said about it. And here you can see comparison between occurring osteomyelitis in maxilla and mandible. And as you can see, in maxilla it's a rare occurrence, and in mandible frequently. Why? In maxilla we have extensive blood supply and significant collaterals. Porous nature of the membranous bones, thin cortical plates, and abundant medullary spaces. And in mandible, it's important factor in establishment of osteomyelitis of mandible is compromise of limited blood supply. And in this case, frequently occurrence of osteomyelitis, and as you can understand, it's more severe for treatment. Acute osteomyelitis is typically suppurative, pus-forming, and generally defined as occurring within 1 month, 3 weeks till 1 month of the onset of symptoms. The organisms excite acute inflammation in medullary bone, and the consequence edema and exudation causes pus to be forced under pressure through the medullary bone, resulting in intrabone blood vessel thrombosis, reducing the vascular supply to bone, which then necroses. Eventually, pus bursts through the cortical plate to drain via sinuses in the skin or mucosa. Where pus penetrates the cortex, it may spread subperiosteally, stripping the periosteum and thus further reducing the blood supply. Clinical findings include intense pain, indurated swelling, paresthesia or anesthesia of the inferior alveolar nerve, cervical lymphadenopathy, and fever. Over time, fistula formation, necrotic bone exfoliation, and tooth mobility may develop. In the early stages, findings on plain radiographs usually may be unremarkable in acute stage, but in chronic stage, only by X-ray we can put the diagnosis osteomyelitis of the jaw. However, the disease progresses and ill-defined radiolucency and loss of trabecular architecture become evident on X-ray or on CTs. Other possible findings include widening of the periodontal ligament, loss of the lamina dura and of the bone, of course, and loss of the circumscription of the inferior alveolar canal, mental foramen. And according to it, patient can feel paresthesia of the one part of the lower lip. It's a symptom of Vincent. When the patient claims on paresthesia or numbness of lower lip. And on this picture or photos, you can see acute stage of acute osteomyelitis, and what are the differences between clinical findings of osteomyelitis and, for example, periostitis. Does it look like each on other? Yes, of course. But the difference in clinical evaluation is that when it's osteomyelitis, you can see swelling of the gum on the both sides of the alveolar bone of the jaw. Vestibular part and oral part will be swollen. And when it's a periostitis, you'll see the swelling only of the one part. It can be or vestibular or oral part. And if it's osteomyelitis, and if you, due to the investigation of the clinical symptoms, will see on patient such clinical picture, you have to know that it's osteomyelitis. And of course, it will be with a high fever or high temperature, up to the 39 or 40. And the asymmetric of the face, you can see and this is photos, real photos of chronic osteomyelitis. It's a clinical picture of chronic osteomyelitis, and it's characterized by periosteal thickening and sequestrum forming. Sequestrums are devitalized pieces of the bone. It's a pieces of necrosed bone, which act as the needles of infection. Sequestrums may eventually be resolved, removed, or spontaneously expelled through the mucosa or skin, but they may persist and propagate a host response. Due to the avascular nature of necrotic sequestrum, they are poorly penetrated by antibiotics and should be removed intraorally and or transcutaneously in surgical operation. Sequestrum is surrounded by the pus, which either spontaneously discharge or remain and perpetuate infection. The periosteum lays down new bone to form the involucrum, increasing the infected and sequestrated bone. An involucrum is a complication of osteomyelitis and represents a thick sheath of periosteal new bone surrounding the sequestrum. The involucrum may prevent sequestrum from being shed. Finally, if little new bone is formed, a pathological fracture may occur, and it's very usual for chronic osteomyelitis, and it can be from 1 month to years. Additional imaging modalities include CT, MRI, and scintigraphy. Management includes drainage, debridement, elimination of the source of infection, antibiotics, guided by culture and sensitivity testing, supportive care, and surgical reconstruction. Early diagnosis and prompt treatment are important for achieving favorable patient outcomes. And as you can see, it's very severe destruction of face, of bones, and it's a general osteomyelitis of, for example, lower jaw, as you can see on these photos. And by arrows, you can see sequestrums. It's necrotizing parts of the bone. It's a dead bone, and we have to remove it. And surgical operation is named as a sequestrectomy. Periapical osteomyelitis is very rare but serious progression of the periapical infection. And as you remember, we were talking about periapical abscess, and if it's not treated, it can cause periostitis or acute form of periostitis. And if periostitis is not treated, it can lead to the periapical osteomyelitis. Or periapical osteomyelitis can be caused after extraction of the tooth. If the dentist extract the tooth and cyst inside of it, inside the bone, isn't eliminated, isn't extracted, and this can lead to this periapical osteomyelitis. Untreated acute osteomyelitis can progress to a chronic stage, which is less symptomatic but just as serious and merits prompt treatment. On this slide, you can see CT, examination of head and neck, and on the left mandibular ramus, you can see osteonecrosis and osteomyelitis, and these parts of the bone, it's a sequestrums, and they are surrounded by involucrum, and you can see asymmetrics of the soft tissues of the face, and we understand that this patient has acute or chronic. How do you think osteomyelitis? Of course, chronic, because we can see formed sequestrum. Acute form doesn't show us any findings on X-ray or on CT. Treatment or surgical management of osteomyelitis should be planned in conjunction with medical treatment. Non-surgical management of true osteomyelitis is futile and only allows for exacerbation of exciting condition and delay of more extensive surgical interventions. In the early stages, surgical intervention should be limited to the extraction of grossly loose teeth, debridement of fragments of the bone, and incision and drainage of fluctuant areas. If the infection persists, further surgical procedures such as sequesterectomy, caesarization, decortication, or resection followed by reconstruction and should be considered. What does it mean, caesarization? It's unroofing of the bone to expose the medullary cavity. And then we'll say about a few words about abscess and phlegmones. What is abscess? Abscess is a circumscribed collection of pus in pathological tissue space. The layer of granulation tissues form the pyogenic membrane, which delimited abscess from the adjacent tissues. And phlegmones, or as I said, in English literature, you will find as purulent cellulitis. It's a widespread festering inflammation of cellular tissues without limitation of separative process. Classification. A lot of different types of classification, but you can have to understand that it can be abscess of phlegmon of maxilla region, mandibular region, bottom of the oral cavity, and tongue and neck. And according to the groups, it can be first group, it's easy one in which we can see abscess of phlegmon in one anatomic region, for example, in the cheek or other spaces of the face. A second group in two and more anatomic regions, and a third group, it's a phlegmons or abscesses of soft tissue of the bottom of the cavity of the mouth, neck, and half of the head. Why? Because it's more dangerous and more severe abscesses and phlegmones for patients, for clinical manifestations, and for treatment, of course. For you as a medical students, it will be enough for understanding that phlegmons and abscess can be superficial bilayer, yes, for superficial areas, and deep or profound areas. For example, example of the superficial area, and it can be cheek, paraorbital, or, for example, submandibular. And examples of the deep or profound areas, it can be for parapharyngeal, subtemporal, and others. Clinical findings, of course, it's a sharp throbbing pain in affected region, localized swelling of the soft tissues, which caused asymmetry of the face, hyperemia of the skin or mucous membrane in oral cavity, in some cases headache and weakness and even temperature, and in sometimes dysfunction. It depends on area of abscess formation or phlegmon formation. Of course, if it's submasseter area, it can lead to the dysfunction of opening of the mouth, mastication, swollen, and if it's parapharyngeal abscess, odontogenic abscess, it can lead to the dysfunction of the speech and even respiration. Clinical pictures, and as you can see, it manifests very well, and it's understandable that it's abscess. By clinical picture, we can't understand it's a odontogenic abscess or it's another types of abscess. But here you can see odontogenic abscess. The cause it's a problem or diseases of the tooth. More often it's periodontitis, but strictly periodontitis, and in acute form or according to the exacerbation of the chronic periodontitis, we can see such formation of abscess. It's localized, as you can see, and not different for examination. And here you can see CT, examination of head and neck. And here we can see abscess and phlegmon. under masseter muscle. It shows us for arrow, and you can see pus inside this abscess or more soft tissues and asymmetries of the face. Phlegmons. And here I showed you different types of phlegmons. On upper photos you can see phlegmons of the deep areas of the face, of the maxillofacial area. Asymmetry, can you see it? Yes, if you see as examination. On the lower jaw, it's phlegmons of the superficial areas, submandible, for example, in the lower right photo. And on the left photo, it's a submasseter. And you can see reddened or hyperemia of the skin, which we can see on the profound phlegmons. Severe swelling of the soft tissues. And here is CT. It's a purulent cellulite of sublingual space with abscess formation. And what is interesting, we can see air bubbles inside this abscess. What does it mean? Air bubbles inside the pus. It means that the course of this abscess is anaerobic bacteria, and such types of abscess and phlegmons are quite different of that which caused by aerobic bacteria. And I hope you know the differences between it. We don't stop on it. And treatment, of course. First of all, if it's odontogenic abscess of phlegmon, we have to extract the tooth. It's the first what have to do the doctors which can treat such a pathology. And then we have to do local anesthesia. Oh, I have even photos, yes, of the operation. And on these photos you can see the stages of abscess treatment or operation of drainage of abscess. First photo shows us clinical picture before the surgical treatment, and we can see phlegmona of the floor of the mouth. Phlegmona or purulent cellulitis, yes, as you can understand. The second picture shows us antiseptic disinfection of the surgical field, and the next it's local anesthesia, infiltrative one. And as you can see on the third photo, we can see green lines on the skin. What for these green lines? Do you know? And I hope that you know, and we'll talk about it in our practices. And now I'll explain you that these green lines are needed to indicate the location of incision. What for we do it before the infiltration, before the anesthesia? Because the anesthesia increases volume of the soft tissues, and it's very difficult or even impossible subsequently to palpate bone points and then to do our incision in right position or in right way. And because of it, we have to do the science on the skin before the anesthesia. Photo 4 and 4, yes, 4, it's incision. Then 5 and 6 shows us pus evacuation. Then 7 and 7A, it's different types of drainage, active and passive. And A, it's operative or surgical dressing. And 9, it's extracted tooth, which was a course of this phlegmon. And the next few words about furuncus and carbuncus, and I hope you all know what is it. Furuncus or boils is a cutaneous abscess that begin in the skin glands and hair follicles, and they are very specific on their manifestations. And can you divide abscess or furuncle? Of course, by visual examination you can understand if it's abscess, different etiology, or it's a furuncus. Yes, inside of it you can see pus and hair follicle. And carbuncle. Carbuncle, it's a few infected follicles which lays together with pus between of it. And on scheme it's shows you. Okay, and how we can treat furuncles and carbuncles? Of course, it's anesthesia, then incision, and then we have to evacuate the pus inside of it and the hair follicle. How to do? It's very difficult. It's not abscess where we can see liquid pus. Here it can be more hard and necrosis. Necrosis tissues can be closely to the healthy tissues, and we can use enzymes to put enzymes inside of this incision. In a day or 2 days we can evaluate the liquid pus. Okay, I hope you understand it. And a few words about odontogenic sinusitis. It can be classified as acute, chronic, and acute exacerbation. Etiology, usually it's a periodontal and periapical diseases, of course, of the tooth of the upper jaw or maxilla, dental extractions, maxillary dental implant placement, sinus augmentation grafts or sinus lift, for example, for putting artificial tooth, and misplaced foreign bodies, for example, during the extraction of the tooth, we can break the root of the tooth or part of the tooth, and this root can be misplaced inside the sinus, maxillary sinus. The clinical presentation of odontogenic sinusitis will vary, but most commonly includes symptoms of facial pain or pressure, post-nasal drip, nasal congestion, purulent anterior rhinorrhea that may be unilateral, foul smell or taste, gingival edema, and fatigue. Obtaining a thorough history, particularly as it relates to dental alveolar surgery, is critical. Of particular note is the finding that dental pain is often absent and in odontogenic sinusitis, and when dental pain is present in absence of other nasal symptoms, it's not specific for sinusitis. However, there were no significant differences between odontogenic sinusitis symptoms and those for other types of sinusitis, only a greater frequency of unilateral symptoms. Careful evaluation of dentition for root fracture, status of the dental pulp, periodontal tissues, presence of an oral antral fistula, and conditions of exciting dental restorations are important components of initial physical examination. And I said about presence of fistula, and we can say about open sinusitis. It can be open and closed. What does it mean opened? When we can find fistula or communication between the sinus, maxillary sinus, and oral cavity. For example, after tooth extraction. And how can we understand if there any communication or not? We can put inside the alveolar some instrument, because if it's not present, this fistula, we can make it, and to have any iatrogenic infection. We have to find any other possibilities for understand if there are any fistula communications. And Valsalva's test shows us such a communication. How to do this test? You have to ask the patient to pinch the nostrils by fingers and open the mouth, and then gently blow through the nose. It's impossible because the nostrils are pinched. And if you'll see the air bubbles, or how we can name it in medicine, it's a boiled symptoms of the boiled blood through the alveolar. It means that air goes through the maxillary sinus and through this communications inside the alveolar bone in the oral cavity, and it means that oral antral communication of fistula is present. And what are the difference between oral antral communications and fistulas? Oral antral communication is a pathological osteomucosal connection between the mouth and the maxillary sinus that appears as a result of various pathologies or procedures. It is communication. If this communication doesn't repair itself spontaneously, it becomes chronic and forms oral antral fistula. That means that oral antral communications, it's after its formation few days, and if it heals itself, it's very good for the patient and for the doctor. But if it doesn't heal itself by itself, it becomes chronic and forms oral antral fistula. About clinical picture I said, and you can see the symptoms on the slide. And here we have a slide about the differences of oral antral communications and fistulas, and I hope you understand it. And here you can see different type of anatomical positions, root of the upper tooth. And a photo of oral antral fistula, you can see that it's more than 1-2 millimeters in diameter, and oral antral communication is less in diameter than fistula. And here you can see CT of odontogenic cysts, which grows from root, which is inside the sinus, and we can see odontogenic cysts inside the maxillar sinus. And here you can see clouding of the maxillary sinus on left side. Yes, in comparison of the right side, we can see that something wrong with the left side sinus, and we can understand that it's sinusitis. If it's odontogenic, you have to find any damaged tooth or any inflammatory process on tooth of upper jaw on this side. And here you can see a tooth root inside the sinus. Doctor was extracted the tooth and part of the root was broken and get inside the sinus. And we have to evacuate it from the sinus and to do operation for it. Treatment. Treatment of odontogenic sinusitis. Of course, we have to start from underlying dental pathology. It can be conservative and or surgical or eliminative. Conservative, it's endodontic treatment with root canal. We have to clean the root canal. We have to put inside of it some medicines for treatment, and maybe we'll treat it, and sinusitis will be treated too. Apicectomy, sometimes it's possible to extract not all the tooth with the root, but part of it which is infected. And dental extraction, it's a surgical treatment. Sinus surgery, in sometimes it can be endoscopic and it's very well. But usually it's surgical. A surgical intervention to close the oral antral fistula. We can do antibiotic treatment, of course, and nasal decongestants and saline aerosols. And about lymphadenitis, and on this picture you can see localization of lymph nodes, and as you can see a lot of lymph nodes in maxillo-facial area and the neck. Lymphadenitis is the inflammation or enlargement of lymph nodes. Lymph nodes are small ovoid nodules, normally ranging in size from a few millimeters to 2 centimeters. The primary functions of lymph nodes is to filter out microorganisms and abnormal cells that have collected in lymph fluid. Lymphadenitis may affect a single nodes, as you can understand, or a group of nodes, and may be unilateral or bilateral. And usually if it's etiology of this enlargement of lymph nodes in inflammatory, it's usually one lymph nodes on one side where we can find inflammatory process of other organs, for example, tooth. For example, patient has toothache for a few days, and then he can find the enlarged painful lymph node. For example, it's usual submandibular lymph nodes or para-auricular if it's upper jaw. And it's a reaction of organism on toothache, of inflammation on the dental part of the face. Of course, etiology of this inflammation can be bacterial, viral, fungal, or protozoal agents or others. Soft, mobile, and tender lymph nodes are likely benign. Hard, non-mobile, non-tender lymph nodes should be raised concerned for malignancy. And if you find a few lymph nodes in one region of the face or of the neck, you have to think about malignant pathology of maxillofacial region. And on this classification, you can see that lymphadenitis or lymphadenopathy can be neoplastic, primary and secondary, and reactive lymphadenitis. Due to the inflammation, it can be acute, subacute, and chronic. And as any other pathologies, inflammation pathology, it can be serous, purulent, and adenophlegmone. what does it mean, adenophlegmon? We won't talk about lymphadenitis symptoms. I hope you know it, because this pathology you have to study in all other um, cycles. And what does it mean, adenophlegmon? It's a phlegmon due to the purulent purulent lymphadenitis. Inside the lymph node, we can find the pus formation when it's a purulent one, and if this pus goes out from the fibrous capsule of the lymph node, we can find adenophlegmon with symptoms of purulent cellulitis, with classic symptoms of purulent cellulitis. But in history of pathology, the patient will say that he found enlarged lymph node. And here you can see the differences between benign and malignant enlarged lymph nodes according to the pain. If it's a benign inflammatory process, it have to be tender, soft, mobile, and if it's malignant one, it's non-tender, hard, and fixed. And here you can see clinical photos or clinical pictures of lymphadenitis or lymphadenopathy and extracted lymph nodes. And of course, on photo 1, it's lymphadenitis according to the inflammation of the tooth, for example, yes, and photo 2, different types of enlargement. And photo 3 and 4, of course, it's malignant one. You can see enlarged group of lymph nodes with different shapes and on one side of the neck. And here the photo of purulent lymphadenitis and and adenophlegmon. Abscess of the lymph nodes and adenophlegmon on photo 3. Here you can see fine needle aspiration for diagnostic to understand what is inside, what inside this lymph node. If they are pus, we have to drainage. If it's something else, we have to do other investigations. And here you can see different types of fine needle aspiration and excisional biopsy and histological inspection. And treatment, surgical and non-surgical. Of course, we are talking now only about lymphadenitis, not neoplasms, not malignant one. Non-surgical treatment, it's a treatment of basic disease. In case of secondary lymphadenitis, antibiotic, of course, anti-inflammatory medications, analgesics, and physiotherapy. If it doesn't successful, we have to do surgical operation. It's incision and drainage or surgical removal of all nodule. Okay, that was all of our lecture. I hope you understand it and it was interesting for you. We'll meet in 2 weeks on Friday at 8 a.m. Thank you for your attention. If you have any question, you can write it on chat. If you have no question, thank you and goodbye. Have a good weekend. Mhm.